In this session this afternoon, we will be basically hearing about social work services that are provided to stroke survivors along their journey of recovery. So we've sourced speakers from both the acute, the rehab, and also the community outreach area where you may come in contact with a social worker. It's important to remember that we've got three speakers up here on my right. We have Nguyen from Royal Prince Alfred Hospital. We have Kate Adin from Royal Rehab. And we also have Deniz, and she also works at Royal Prince Alfred Hospital. So we'll be taking questions from the end after all three of the speakers have concluded their presentations. So our first speaker is Jenny Nguyen. Jenny is a social worker with 2 years clinical experience. She works at Royal Prince Alfred Hospital, specialising in neurology and neurosurgery. Her work centres around supporting patients, families and carers in an inpatient acute hospital setting. And Jenny has a particular interest in research and supporting carers and also undertaking her research. So thank you, Jenny.
Thanks for having me here today. Is this loud enough? Everyone can hear me okay here? Okay, that's good. So I'm Jenny, and as mentioned, I'm the neurosocial worker at RPA Hospital. You've already got a bit of my background already, but before I was in stroke, I was working in women and children's health as well at a different hospital. So in talking a little bit about the social work profession, social work itself is quite broad, but in terms of hospital social work, I've drawn from the Australian Association of Australian Social Workers for the definition, which is that hospital social workers provide direct services to patients and their families and carers, including significant others, aiming to minimise the negative impacts of illness and hospitalisation. A hospital social worker's role is to enhance social and emotional functioning through targeted interventions and the mobilisations of services and supports. So in other words, the social work role is underpinned by what we call a biopsychosocial lens, which locates understanding every person in the context of the biological, psychosocial and social factors. That's to say we're more than just our age, our gender, our medical history and our diagnoses. It's important to understand a person's holistic health and well-being by also factoring the psychological, such as coping, or social elements, such as our environment and our relationships. And so with mobilising supports and services, you consider informal and formal supports, existing and new ones. So that's the overarching idea of hospital social work. So what makes acute stroke-specific social work different? First, I just want to mention a little bit about the RPA context. You may have heard a little bit about it before with what the stroke service offers. So it's just mentioned there, the stroke unit, thrombolysis, 24/7 clot retrieval, which is 1 in 4 of New South Wales, including transfers from rural and remote areas. You could say we're a very busy hospital. It's an excellent multidisciplinary team, and I'm very privileged to be working with such passionate and knowledgeable people. We've got 10 neuro ICU beds, 30 neuro ward beds, and 2.5 full-time neuro social workers. So there's 1 in ICU. I am one of the full-time ward social workers. My colleague Deniz is the other 0.5, and she does 0.5 outpatient work. And we also have ED as well as an on-call crisis service, so that's after hours. So I think it's important to acknowledge the context I work in because, of course, everyone's stroke experience and journey is very different, and it can be shaped by which hospital you were at. So I also want to acknowledge there's plenty of room for learning and service development for us all. So it's really great to hear about lived experience from those who have been affected by stroke. And so oftentimes when one of the first things is people come through ED, not everyone in ED will get seen by social work unless there is significant distress or other immediate concerns, such as child protection or carer arrangements. And the reason for this is the emphasis in the ED space is that medical workup, the medical stroke workup. We want to get you out of ED to somewhere that's more appropriate, whether that be ICU or the ward. And so oftentimes in ICU, it's that crisis context. And there's a great deal of shock and hopelessness in the initial stage, in that time of uncertainty, particularly for families and carers. And supporting people can involve crisis intervention, such as crisis counselling, de-escalation, the psychological first aid, which is similar to crisis counselling, but crisis intervention, but also it can also be practical things like reminding people to have some water, take a seat. These are the private spaces, you can take some time out, reminding them to draw on their families and friends. There's grief counselling, including anticipatory grief. If someone passes away in hospital, the social worker can provide information about those processes, such as funeral processes, bereavement supports, and bereavement follow-up. The support for families with family meetings. Oftentimes in ICU, those meetings can be about discussing heavy topics such as end of life or advanced care planning. So it can be really helpful to have social work support there to help process and understand the information, to advocate, and just the support after those sorts of meetings. It can be already so overwhelming and hard to absorb. And so my understanding of the ICU space is it's a precarious space that you take one day at a time. That's the big emphasis of so much uncertainty. There's not a lot that can be promised, but that's a very uncomfortable place to be sitting. And so there's a lot of emotional support for patients, families and carers in that almost like crisis context. And in terms of transitioning to the ward, the transition from ICU to the ward or from other places to the ward can be unsettling for some people, particularly those who have stayed in ICU for a long length of time, because there's changes in how nursing is provided, going from sometimes 1-to-1 nursing to 1-to-4. And for a lot of families and carers, there can be a sense of loss in that change because you're losing the relationships you have with the workers that the point of contacts. And when there is so much uncertainty happening, it can be that sense of you just want one thing to be sure. And so it's important to emphasise on the assurance and reassurance that transitioning to a ward is a crucial and important step. And ideally, we don't want people to stay in ICU for longer than they should. In terms of the types of interventions social workers provide, I often get a handover from my colleagues for that continuity of care. I also talk a lot to the multidisciplinary team, the allied health team in particular, to understand what's happening in terms of strategies in approaching things like behaviour, communication, cognition. All those things are really important to consider before I meet the person, before I speak with the family. Prefer not to make them keep repeating things that they've had to say again and again. And so there's something we do called a psychosocial assessment, which involves assessing, basically understanding the person in their social context. So what's your supports look like? What's your home environment look like? What's your finances? Are there any risks we need to consider? What was your previous capacity and functioning? Better understanding of your illness or your goals for the future. There's also scope for counselling. On the ward, there's a lot of room for adjustment counselling a lot of the time. So exploring the emotional and social responses to the impact of stroke, the fear of loss, anxiety of sitting with uncertainty about what the future holds. For some people, it includes some loss of a level of independence and autonomy, and the mixed emotions around this. I find this particularly comes up for people who are used to being like the providers of their family, or those that are used to caring for others. So to suddenly need to ask for help is a very uncomfortable position to sit in, and so there's a lot of adjustment around that. And for some couples or other relationship dynamics, there's also an adjustment for the other person, the family member. The relationship dynamic can change when suddenly you're thinking about what it means to become a carer for the first time and what it means for plans for the future. Some couples have talked to me about changes in their plans for travel, and so there's a sense of loss around that they're exploring. There's also grief counselling that I mentioned. So that can come up if someone happens to be palliative or end of life. But it also links back to the whole adjustment counselling as well, with changes in your function and mobility, which may or may not be regained. There's a lot of carer support as well. So supportive counselling around that, the psychoeducation around self-care and burnout, reminding carers that, you know, they have the support of the hospital staff. This is a great time to take a bit of a breather for yourself. Sometimes people are coming in every day and getting really, really tired and feeling guilty for feeling tired. So exploring those emotions, validating them, but also gently challenging them to be able to think about caring in a sustainable and healthy way. And so there's also the provision of resources, referrals and supports. So it kind of links into education, resourcing and practical assistance. So some of the resources I'll explore is like insurance can come up. So for people who have a stroke and can't work, exploring if they have any income protection, any sort of total permanent disability insurance, which people don't realise they may have because it was default on their superannuation, or any other forms of insurance, because that can help alleviate some financial stress. NDIS is something for people under 65. Oftentimes if someone's going on NDIS, they'll be going to rehab. So broaching that conversation, talking about the possibility of supports and those sorts of things, but also carefully treading the line of maintaining hope, because we don't want to talk about permanent disability and demoralise someone. My aged care is something as well, so that's for people over 65 or for Aboriginal and Torres Strait Islanders over 50 years of age, so that can be services and supports at home. It can be in a facility, an aged care facility, respite or permanent, what that looks like, the processes around that. Centrelink often comes up as well with financial supports, so disability support pension, which can take a longer to apply for, or else carer payments and carer allowance. Also assisting with patients, families and carers with communicating with the team. You know, sometimes they have questions that they're afraid to ask. They don't want it to seem like they're asking too many, or they don't want to seem like they're asking the wrong questions. So encouraging them to voice those so that they're not managing that kind of anxiety on their own, or having a place where they can go to start to feel more comfortable. And a lot of the times it comes back to understanding the medical information too, and that's where a lot of advocacy can happen, to make sure sometimes we hold the concerns themselves and sharing that so we better understand each other. There's case management with coordinating if a person's to leave hospital, they're being discharged home or to somewhere else, what that looks like, what kind of supports and services are options. And so there are referrals to services such as Compacts, which is a 6-week service, other organisations like Stroke Foundation or Synapse as a brain injury support organisation. Carer Gateway comes up a lot. Plenty of carer supports too. For other people, there's handover to rehab and outpatient rehab follow-up. And yeah, basically along those lines, depending where you're going next, there needs to be that continuity of care and making sure that you're linked in and know where to go if you have questions. And so I mentioned a little bit about handover to rehab. You'll hear a little bit about the rehab social workers' perspective on it too, but it's just a lot of the times it's ensuring that the patients, the families, the carers, they have an understanding of the rehab process. And I've found recently a lot of carers are really fearful about the future because they feel like they're expected to provide all the cares that they're seeing in an acute hospital setting. So providing reassurance about the services and support options, that they'll continue to receive social work support, particularly around discharge planning. For other people being discharged home or facility, so there's the handovers required in that and coordinating and the service referrals. You'll hear a little bit more about the outpatient work from my colleague Deniz as well with the stroke outreach service. I think the important thing to highlight that the goal with discharge planning is to ensure that people leave hospital with a safe and supported plan, that they're equipped with power and knowledge about what to do. And so as a social worker, it's such a privilege to be included in a person's stroke journey. The emphasis I find is no matter where you're working as a social worker in that stroke journey, you want to remain person-centred through the entire way. It's important to empower people with resources and knowledge and maintain a sense of hope for the future, for the patients, for their families, for the carers and for their loved ones. And that hope can come in different forms because we know the stroke journey can look so different. I think of it as hope for recovery or hope for dignity and ultimately hope for a future post-stroke, maybe for yourself or maybe for others who will come, who may be part of the journey in the future. So I think a forum like this shows how far the stroke journey has come in being better understood, in providing a forum for lived experience to be heard. So I think there is plenty to look forward to. And yeah, thank you for listening.
Thank you very much. And I guess one of the things about that acute phase for you is that it can be very short. And so linking in with a social worker even at that stage, you really have to really be lucky. So it's great that RPA provides that service and such quality social worker to do that. So thanks very much, Jenny, for your presentation. That was excellent. So our next speaker is Kate Adin, and Kate works at Royal Rehab. And Kate graduated as a Bachelor of Social Studies at the University of Sydney, but we really won't hold that against her, okay? Some of us much prefer the people who come from the University of New South Wales, just putting it out there, yes, okay? There is this hierarchy, there is, okay? Upon graduating, she worked in the health system and child protection in London. Upon returning to Sydney, she worked in the field of adoption, palliative care and the New South Wales Trustee and Guardian before moving to Royal Rehabilitation Services 5 years ago. She works with the community-based rehab team, which covers the public outpatient department, the home-based program and the Transitional Package. In this context, she has worked extensively with people that have experienced a stroke. So thank you, Kate.
Really good introduction, thank you. And we get to see, or I get to see people after they've come home from hospital, usually within the first week. So I guess that's kind of important. Anyway, so we get to see people when they're home, and it is when, in a way, reality hits about what does this mean? What does having a stroke mean when they talk to you about, some loss in memory, or the person needs to be assisted when mobilising for everyone. The introductory thing is that we are a general service for rehab, and we visit people in their home, so that's the focus. By general, I mean not specifically stroke or any other health issue, but all the issues that can come up for people, including having cancer, having a heart attack, having a fall and a fracture, and neurological diseases. The big thing is that by and large they need to be in hospital when the referral is made, and that there's been a fairly large change in their health and well-being and independence. So the first program that we've got is the home-based rehab program, and sorry, just our catchment area for all of our rehab is the Northern Sydney Local Health District only. So the home-based rehab program is basically for people over 18, and it's 6 weeks unless a person has a stroke, and then it can go up to 9 weeks. We're a multidisciplinary team: social work, physio, occupational therapy, dietetics, speech, horticultural services and recreational services. The referral is always from hospital while people are still an inpatient, and so that's that. I'm also part of the public outpatient department at Royal Rehab, and the referrals for that can come from hospital, but people don't usually, they're folk that are living at home and do not need a home-based rehab program generally. So they're much more independent, and they need to attend our outpatient department. Folk need to be under 65 to be referred, or if they're still working and over 65. Again, varying health conditions, and how long they attend really is determined in 12-week slots. So we have a goal review at the end of each 12 weeks. We go, okay, what do you want to work on next? And so forth. So people vary in terms of their attendance from up to a year to 12 weeks. The Transitional Care Package, has anybody heard of that? Again, comes from hospital, and it is specifically for people over the age of 65. It requires an aged care assessment. Again, the person needs to be in a hospital setting before the referral is made. And the TransPack consists of a home-based rehab part and like a home care package part, so that families get care support like cleaning, shopping, personal care, etc. And because people are over 65 and overall in their 80s, the thinking is that there's a longer recovery time, really, that's needed. Okay, so let's have a look at the next. So all of it is actually one team that just moves through these different programs, the same team. Multidisciplinary team. Referrals come from my colleagues. They come from the original source of referral where social work's identified. They come from the case manager of the TransPack, the client themselves. But for people that have had a stroke, there's an automatic referral because of the potential changes to life and to everyone. Just to say that we did a little bit of a count of the last 12 months, and we found in outpatients and the home-based program, 30% of people have had a stroke in the last 12 months of our clients, and 40% of them have got are under 65. So that's quite a new trend for us. So the context, like, it's important to know when we see people, because that determines what we do and what support they have. So it's that coming home when reality hits about what effect whatever health condition has had on folk. And I just wanted to say that we use the idea of loss and grief theory quite a lot to make sense of what people are going through. And the idea of, the way I kind of understand it is that, you know, loss and grief is about letting go of something you can no longer have and turning towards something that you can have. But it's a long process, way beyond how long we see people. So social work basically has two aspects to it. The first is supportive counselling, as my colleague had mentioned. And a lot of that is, again, acknowledging that life has changed, whether a lot or little, and for the moment, and that there is a time of uncertainty for everybody, where you're not sure, like, how well will I get, and what does that mean? So it is really living in that chaos of going in one direction and somebody pulls the rug from under you and now you've got to get up and kind of keep going and you don't know. So that's an important factor, and the approach that we tend to use with that is, talking about acknowledging what's happened, acknowledging, yes, life is chaotic at the moment, or different, then looking at, well, people have lived a long time and they've developed ways of dealing with, you know, with challenges in life, and acknowledging those and highlighting them to say, okay, well, this is what helped you the last time when you lost your parent or when you lived in a time that was uncertain. And then we talk about, well, what can we add to that? You know, is there anything additional that would be helpful at the moment? As my colleague has said, the work is with the client and with really important people in their life. And usually that often is the family members and the spouse. And as to how much of that is with the person and how much is it with the family member really depends on the situation, and partly depends on whether the person's had a lot of changes around their memory, and then the focus is more on the family member because they need support to implement things like rehab. Sorry? Oh, sorry. Okay. Thank you. And a part of grief is the feelings that arise is anxiety and stress and being overwhelmed and losing hope, which is really what depression is as well. And again, acknowledging that, but also saying that people move from one to the other. They move in and out of hope. And I think often the point at which my colleagues would refer is when someone's like, I'm too anxious to get up and try walking, and I don't want to participate in rehab because it's too hard and it's not going to make a lot of difference. And I want to... So it's validating that, as you've said. The other thing is that we're getting a lot braver and acknowledging that there are changes post-stroke to perhaps neurologically to people, and the intimacy part of the marriage can be affected, and it's opening that conversation and acknowledging it. The other part of the social work role is a very practical one that you've already stated, and the My Aged Care, and we all know that at the moment they're really short-staffed, so the services are limited. Sorry? No? Okay. But providing information, access and linkage to, say, to My Aged Care, talking about the National Disability Insurance Scheme, and often that is deferred to when the person comes home. And that is really tricky, not just from a hope point of view, but because of the criteria for NDIS, which is you don't qualify unless somebody says this is permanent and therapy is not going to make a big difference to it. So, and in reality, people improve. So that's the tricky thing with it. But on the other hand, if you're under 65, where do you get support? So those are some of the dilemmas. And finances, yes, as has already been mentioned, talking about that for the first time. Stroke specific, the Stroke Recovery Association, men in particular love Enable, I found, and they get on there and listen to the TED Talks. And I remember one gentleman we're working with at the moment was really interested in that, in his fear of this can happen again, particularly since he didn't have the usual pre-existing health issues that people sometimes have. And it's that sense of what can I do? So he found that talk really useful. Peer support. Now, sometimes people are not quite ready in those few weeks of coming home to actually link up with a stroke club or even to go online. But what they find really helpful is talking to someone who's ahead of their stroke journey. So we've got, they're not here, but a couple, Bill and his wife, Sue, I've forgotten her name. Thank you. Mr. and Mrs. Yes, Gooley. They actually meet with couples often, and they talk about, this is the effect it had on me as the spouse, this is what I needed to do, these are my extra responsibilities, versus this is what happened to me. And Bill would say, it took me 12 months to realise I actually can't go back to work. So it's a long process, and find it really useful. And at the moment, I'm trying to do a little bit, even people that are not quite that far down the track, but people that I'm working with in outpatients, and like linking a man who has just started going back to work 2.5 days a week with somebody further down the track who's actually negotiated to work part-time, and how he did that and how that's working for him, and, you know, working on how do you say no to a really big workload. And then I linked the middleman with somebody who's a new stroke, who's just looking at, really focused on getting back to work, but still hasn't nailed things like, well, you can't drive, you're really tired, and you need to use public transport. So it's sort of, and it's working really well. Counselling ongoing is really hard, actually, because it costs. Unless you've got, for family members, you've got the Carer Gateway that provides some free counselling, but also a great information kind of source as well for when people are more ready, you know, when the emergency is a bit more contained and they've got a bit of space to think about the future. Brilliant, brilliant services. And I'm just mentioning, thank you, mentioning specific stuff for people if they've got multiple sclerosis, linking them to that society and peer groups. And the last thing is just, a lot of the time it's ongoing. Sort of, we all do, if you like, education, because in the hospital setting you get a lot of information given around, you know, all of a sudden the person's more impulsive or they actually need supervision when they're walking. what that means when you're home is the bit about, and reminding like, well, that's the effect of the stroke. That's what that means. So what can we do with that? What can we do so that you've got a bit of time, etc. So, and I guess the very last thing is, so remembering our role is for a brief period of time when people come home and the reality of the effects of the health condition becomes apparent in the home situation. It's a journey that takes many years for people. So our aim is to at least make sure, if we can, that they're not isolated, that they're linked, and that they know who to go to when they need that. Thank you.
Thank you, Kate. Now I'm going to introduce you to Deniz, and she did go to the right university, I'm going to say. So she works in both the acute stroke unit, multidisciplinary team, and the stroke outreach service at Royal Prince Alfred Hospital. Deniz sees her primary role to provide emotional support to stroke survivors, their families and carers, as well as assist them to navigate the complex system that is NDIS and the My Aged Care processes. Deniz is also involved in post-stroke mood screening, which is a really critical part of the services provided at RPA Hospital. And Deniz is a new graduate working in the field of stroke for the first time, and she's keen to expand her knowledge of stroke. She's part of a statewide peer support organisation and supervision for social workers, with a focus to share their knowledge and also learn more about the experiences of other social workers who are working in the field. And as part of that team, they're also looking at identifying gaps of where social work services need to be increased or improved throughout the state of New South Wales. So welcome, Deniz.
Thank you so much for that introduction. So thank you for the opportunity today to speak to the social work role and the work we do in supporting stroke survivors and their families. So I've been in the role of a clinical social worker at Royal Prince Alfred for about 9 months now. And my role is unique in that it is comprised of both inpatient acute social work with stroke survivors, as well as within the community through the stroke outreach service. Yep. So the stroke outreach service is a home-based rehabilitation service, which is based at RPA Hospital. However, it offers rehabilitation to stroke survivors across the entire Sydney Local Health District, which is actually a lot bigger than you would imagine. And so the stroke outreach service is a multidisciplinary team. So we have occupational therapy, physiotherapy, speech therapy, and myself as the sole social worker. So typically, clients are referred to our service on discharge from hospital or discharge from a period of inpatient rehabilitation. Or a little bit more rarely, they can be referred directly from their GP. I guess the purpose of the stroke outreach service is to work with stroke survivors to develop client-centred and more personalised goals, which are community-based, and it's a less intensive model of therapy to gradually meet these goals and adapt to post-stroke changes. Often these goals can look like people wanting to get back to work in some capacity, people wanting to, catch public transport independently, which is things that we just don't always think about when you're in hospital. But once you go home, you start to really realise what things are the most important to you in terms of regaining your independence. And I believe this service is effective in not only supporting stroke survivors to meet these practical goals, but also in linking people in with the right supports and services, educating family members and carers, as well as offering the emotional support during a really difficult stage of the stroke journey. And I believe we believe that it ultimately reduces the risk of deterioration in the community as well as readmission to hospital. So a bit about the social work role on the Stroke Outreach Service. So while most stroke survivors can face a similar set of issues, I guess everyone's social situation can look a bit different. And I guess the way that I understand my role is I'm really there to help alleviate any of those pressing social issues that might be impacting upon an individual's ability to kind of engage meaningfully in therapy. So a common concern, as my colleagues have mentioned, can be financial. So often when people return home and begin to kind of process and resume a regular routine, they're faced with not being able to maybe return to the job that they were in or the role they were in. Sometimes it is also carers who are kind of experiencing significant stress as they find they're providing such a high level of care that they also are unable to resume work to the capacity that they were. So this often leaves families with really significant financial strains. And unfortunately, accessing financial support through Centrelink is not always able to be initiated in the acute setting. We just don't have the capacity to do that. So often I find that I sit with people and provide practical support, like completing that mountain of paperwork that you usually have to, liaise with different health professionals to help people gather that medical evidence that they need. And together we kind of alleviate some of that anxiety and stress of making those really long phone calls together and navigating really difficult to comprehend systems for anyone, let alone someone who's just gone through such a traumatic admission at hospital. And sometimes I find clients and carers are left without direction in terms of how they're meant to progress their applications. And to be honest, sometimes it's just about validating people's experiences, particularly if they've never had to engage with these systems before, and just acknowledging that they're not always accessible, especially when you've got maybe cognitive or communication deficits post-stroke. And it can be particularly distressing to have to, engage with these systems for some people. And depending on their, I think my colleagues touched, but depending on their personal circumstances, just providing the information around accessing insurance and superannuation can be really helpful for some people. And outside of financial concerns, primarily I find that clients and carers need support navigating things like my aged care and the NDIS, which we all touched on a little bit. And I guess I kind of meet people when they're at various stages of that process. And I won't go into what my aged care and NDIS is because we've touched on it so much. But some things that I find most people find particularly helpful. So these services mean people have access to in-home supports in the long term. So things like domestic assistance. What's most important, I find, for a lot of stroke survivors is transport, because it is almost impossible to get back to driving for some people, and if not, it's a very lengthy and expensive process. Those kind of supports can be really crucial for people's quality of life, and it can be quite confusing to navigate those systems. It's not very easy. Unfortunately, it is very underfunded at the moment. So there's a lot of lack of staff, and COVID has not helped. So it can be very difficult to even find a service provider, let alone when you do get your funding. So I guess part of my role is really sitting with people and problem solving sometimes, drawing on other resources like Carer Gateway. I've found particularly helpful, particularly over the last few months. They've been really filling a gap in services. And I guess the final part of my role is counselling and emotional support, which my colleagues also touched on. I guess when people get home, it really sets in that our roles might have changed, our dynamic in family units might have changed, our interpersonal relationships and the way that we identify has changed, and it's really about sitting with that and processing it. And sometimes I find myself just mediating these conversations because they can be really difficult to initiate with loved ones, and we're kind of always in survival mode, and we kind of go and have to engage with therapy, and we don't take the time to really voice what's going on in our heads. And I guess that's a good segue into the other part of my role, which is mood screening. So I'm sure we've touched on it quite a lot today, but people who experience a stroke tend to be at a higher risk of developing altered mood. And part of my role in both the inpatient and community setting is to really initiate this conversation early, usually within the first month or so. Post-stroke, we like to have this conversation so that stroke survivors and families are aware that noticing some changes in your mood, such as, heightened anxiety, having more racing thoughts than you normally would, or noticing, significantly low mood, is really common, and we don't want people to kind of go home not knowing why they've noticed some changes in their loved ones or themselves. It's important to recognise that while these changes can be common, it can also really impact upon engagement with therapy, impacting overall the motivation and drive for people to continue working on their goals and engaging with therapists. So I believe that monitoring mood through regular screening is really important for the overall recovery journey that all stroke survivors go through. And a benefit, I believe, of my role is that I get to kind of see patients both sometimes on the ward before they go home or go off to rehab, and I can mood screen them. And then sometimes they end up being my community clients, which is great. So I can mood screen them again and see what has changed, what might have been the reason for that change and what they've found helpful. And I guess I won't go into the research, but it does suggest that it is really important to not mood screen just once over the whole journey. As we know, it's a lifelong journey, but to kind of have that continual checking in and making sure that we're not making people sit with any significant mood concerns. Yes, sorry, I've just lost where I am. So yes, one of the primary aims is to be able to, I'll just touch very quickly on the peer supervision group that we've come up with. So me and the social worker over at St George have put together a peer supervision group for social workers across New South Wales, particularly with one of the aims being around monitoring mood and assessments with stroke survivors, and being able to share information around what has worked and where there are gaps and what we're missing in terms of when people go home. And while most of the screening tools can actually be self-administered, I think it's important to acknowledge that when you have a holistic view, we're able to take into account people's supports and people's access to family and friends when they go home, people's informal supports and formal supports, and any history that would impact upon mood screening. I will touch very briefly on the screening tools because I know they're not too relevant. But I guess the interesting thing is that so we consider post-stroke mood screening with both aphasic and non-aphasic patients. So when stroke damages the part of our brain which controls the use of language, it can mean we have some communication deficits. So if an individual is identified as not being aphasic, they can engage with our hospital anxiety and depression scale or the patient health questionnaire. So these are very straightforward, multiple choice questions. And I guess if they do present with aphasia, there are other tools that we can utilise. So if their aphasia is expressive, which means their use of language is impacted, but their receptive language is still intact, we can use a set of cards so they're able to communicate by sorting the cards into true or false piles. If their expressive and receptive language is impacted, then we have an assessment tool that really draws on the carer's impression. So the impression of their behaviour is able to give us an indicator of whether they might be in any emotional distress. So those are just some of the tools that we use. And to wrap up, so what do we offer people when they do indicate that they might have some concerns around their mood? So in the acute setting, this can look like referring for psychiatric review if the person would like that. And I think earlier on, someone also touched on medication. So yes, that is something that we often do see is quite helpful in the clinical setting. It sometimes means really practical changes like sun therapy, just getting people out of their hospital beds and into the sun can make all the difference sometimes. So it means kind of advocating for them and sometimes it's the simplest things like asking what they would be doing if they were home. And sometimes people say, well, I just really like a really good book to read. And that can mean that their mood is, supported in that acute setting. In the community, it can mean ensuring that clients have access to crisis services. So obviously my capacity is a bit limited in terms of emotional support, but if people have access to 24/7 support, that's really important. The mental health line has been a great resource. It's meant I've been able to link people in to really practical community crisis teams that can get them linked in and reviewed by psychologists in the community. And depending on the individual circumstances, I can support them access a mental health practitioner. Yeah, and I guess to sum up, I guess on theme, a large part of my role in the way that I understand it is really creating connections. It's linking people in and encouraging them to reach out to supports and really putting some long-term supports in place and trying to help support them navigate these really complex systems. And thank you. I will get off now.
Thank you very much, Deniz. It was wonderful. And it's great that we've actually been able to hear from a number of speakers today. And we are aware that we're presenting to you people who come from a metropolitan situation who often have the ability to work in a specific health issue to do with stroke, or at least across a few. And a lot of social workers work in a rural setting where they may be dealing with the whole group and the whole gamut of what's coming into their hospital. And social work services, I'm going to put a plug in here, is always an under-resourced service provided by New South Wales Health, and whether that be in the community setting or the health setting, we're always the first to go, can I say? I'm just saying, but that's great. So now I'm going to stop talking and open it up for questions. So do we have anybody who has a particular question for any one of our speakers up here today?
A couple of things I raised this morning was the word hope. I hope I give people hope because I had a stroke 11 years ago and I'm out doing long distance triathlons and I returned to work a few months after my stroke. Look, I'm involved in the program with Deakin University, the return to work, the stroke people in rural environments, and it's opening up as well. One perspective that I keep on coming up with is that when I returned to work, there was a huge amount of paperwork that my brain couldn't handle and a huge amount of bureaucracy to get over. Now, that's something that somehow or other, I imagine it's still very much the same, that's something that somewhere along the line we've got to manage to cut down on, because I remember at the time that I ended up on blood pressure pills because of it. Things like the brain scan and all the paperwork your employer wanted and all the rest of it. Now, one thing that I had the support of my union, but that helped me to return to work. But so often workers today don't have that support. I believe there should be some sort of legislative support for survivors when they return to work, so that and it probably needs to be ongoing, so that there's social work, so they've got someone that they can call on and somebody to help them.
Yeah, so your question is, with all the paperwork that's involved in, I guess, getting people either back to work or even back to the community, they're often complicated forms to fill out. And I think the social workers have touched on that as well. So I'm just wondering if you could just touch a little bit more on the sorts of issues that you might be facing in regards to filling out forms, because you do become expert at it. And everything's done online these days. And the other issue, particularly with places like Centrelink, is that they often won't talk to the advocate. They'll only talk to the person. And if somebody has an issue with communication, that can be an issue. And the other thing is, I guess, even the carer can often not be precluded from acting on their behalf. So we're just fixing up the microphone. So I'll get Deniz. Are you going to address it, love?
Hello. Oh, can you guys hear me? Yeah. Okay. Yeah. So I guess that's a really good point. One thing that I've experienced on my service anyway is that occupational therapists can be really vital in the community role, because that's exactly what they can do, is they can kind of provide you with a really clear indicator for what your capacity is, and be that middle person to liaise with workplaces and human resources, to kind of say, yes, this person can return to work, but to this capacity. And I believe someone spoke to it a bit earlier today about really staggering your return and really acknowledging things like fatigue, things like, attention being impacted and focus being impacted are really real realities for people. And we would hope that most workplaces would be really understanding of this and accommodating of this, and make a return to work quite accessible. I guess in terms of the social work role, it's not always clear. It's a bit of a grey area. I do find that, getting through paperwork is definitely something that I can help people with, but it's really more about encouraging them to communicate really openly about what their capacities are, and not to kind of go in and say that, you can fulfill the role in the way that you used to. I think across the board, it's just about acknowledging that you can do the same things, just in a bit of a different way, and maybe in a way that's a bit slower, but in a way that, you do have lots of support, being able to do the same things. I'm not sure.
Oh, okay. Yeah, do you want me to add to that? We had a really interesting question around that, not so much about paperwork, sorry.
Thank you.
And it was about this gentleman who said, do I have the same rights as if I had a work-related injury versus a stroke? And it's interesting that the answer is that there is no legislation around if you have a stroke and it's not connected to your work. So it's very much about the relationship between the employer and the employee. And I think that the employee is quite vulnerable in terms of, like, how do I, I'm really anxious about going back, not sure how I'm going to go, because that again is new territory that I've got to walk again and see how far I can go with it. But we do, and in reality you won't know till you try it. And that gentleman that's gone back 2.5 days, actually had practice doing some reports for work and synthesising information. But when he actually went back, he's finding it quite overwhelming, and where he loved work, he's like, oh, I don't know about that. There is the occupational therapist, brilliant. The social worker's role is around encouraging and saying, remember that you're brave enough to give it a go, but we don't know what the result of that would be. He is fortunate, he's got a very good employer. But the other thing is, and I don't know their name, that there is an actual independent organisation that, if the employer is happy, is able to do those negotiations about a return to work. But at the moment, most of it, for that gentleman and for a lot of our clients, has been around talking to their rehab specialist or their neuropsychologist.
Thank you very much. That's great. Do we have another question at all?
So a question online for Jenny. What type of procedures do you have in place at RPA to make sure that everyone gets seen by a social worker and provided with a discharge plan?
That's a tough question. The blanket referral for social work with people who've had strokes is for mood screening. Whether or not they're appropriate for mood screening is acknowledged in the file. So that is more Deniz's role with the mood screening. In terms of discharge planning, I think it's not necessarily... I don't think it's necessarily a bad thing that not everyone needs a social worker as much. I think everyone would benefit from more resources and education, and I also acknowledge that there's a certain level of capacity we have in the hospital setting to be able to see everyone for case management, for discharge planning, for things like, you know, forms and Centrelink. Those things unfortunately take a lot of time, and it's where we work with families and carers a lot for that support. I don't know if that answers the question sufficiently, that unfortunately we don't get to see everyone. There's room for data to be captured when people aren't seen as well, just to, in terms of funding for more roles. I don't know if there's anything.
Yeah, and I guess it really depends on circumstantial things. So there are things that can be really clear that indicate that someone really would benefit from discharge planning and social work input. And again, we have a great multidisciplinary team, so those kind of things generally get flagged. I guess the good thing is specifically strokes are blanketly seen by physiotherapists and occupational therapists, and they tend to be really, really good at getting people to speak about what their home life is like, what their occupation was prior to their admission, things like that. And often that gets shared within, you know, the team, and we're able to flag when likely, you know, if someone was a taxi driver, they're not going to be able to drive for at least a month or so, and that gets flagged immediately, and we're able to respond and say, well, do you have any concerns around not being able to return to work? So things like that, that's just one example. But again, yeah, like Jenny said, unfortunately, we are a bit limited in our capacity. So if things are not flagged, particularly when people are a bit younger, or they've got, you know, a really solid support network, that we unfortunately don't get to discharge plan, which it's sometimes not you know, immediately necessary. But yeah, like Jenny said, I think we'd have to say that everyone would benefit from social work input. Yeah.
Oh, we definitely say that. We definitely say that. So that brings us to the end of that session, and I do thank the ladies extremely much for presenting for us today. It's not easy to get up and try and explain the social work role, because it's often a lot of the esoteric stuff and the emotional support that is often really difficult, I guess, to measure and also to realise the importance of. But I guess the key issue is that they are there. Always ask for them if you need one. And the other thing is, as each of them have pointed out, that they play a very important adjunct role, I guess, to the multidisciplinary team that works together, and everybody within that multidisciplinary team interacts and talks about every patient that comes through a hospital at one stage or other in the stroke journey. So my thanks to Deniz, my thanks to Kate, and my thanks to Jenny for a wonderful presentation this afternoon. Thank you very much.